Hello, I'm Dr. Elliot Walters, presenting on debridement strategies, assessing operative debridement through the use of MolecuLight. I have no financial disclosures. Operative debridement is the gold standard for debriding wounds in a chronic wound patient. We typically use tools such as curettes, rongeurs, scalpels, etc. And one thing we don't understand is really how this operative debridement affects the bacteria within the wound. Now, let me start with a case. This is a 73-year-old gentleman, has a typical profile for patients presenting with lower extremity wounds. When he presented to our clinic, he had normal vitals, no complaints or evidence of infection, and a white count of 8. Now, if I were to ask any of you, you would tell me that there is bacteria within this wound. But my question for you is, where is the bacteria? Now, we have several different methods for detecting bacteria within a wound. Most commonly understood is the swab culture. This is widely available. It's been around for a long time. Problems with it, though, is that it has a limited bacterial quantification. It requires 24 to 48 hours for any kind of result to come back. And it may not necessarily grow whatever it is that's in your wound. Now, we also have quantitative PCR. This does have limited availability and still takes up to a day or more to get a result. It can quantify the bacteria, but again, it does take time. Next generation PCR gives us more information. It will identify all of the bacteria within a wound, but it does take some time to get a result. Again, up to 1 day, and it has limited availability. Finally, we have fluorescence imaging. Now, fluorescence imaging can identify exactly where the bacteria is, but it does not give us any speciation, and it cannot quantify the bacteria within the wound. Now, biofluorescence is not a new concept. This has been around for decades. We're all familiar with these images of cells that have been fluorescently dyed. It's been used in the lab extensively and is now starting to find its way into the operating room. Well, a group out of London, led by Lewis Dartnell, found that many of the common bacteria that we see within our wounds have similar excitation maxima to each other, at around 230 to 280 nanometers. And you can see all of these different bacteria show about the same peaks. Just for an example, this is a water bottle out of my office that shows some small speckling of red in the outlined area, which also corresponds to bacteria. Now, if we go back to our original image, we see certain spots within the wound that fluoresce with this red bioluminescence. So we designed a study around this with 2 questions. 1, does excisional debridement significantly reduce bacterial bioburden? And 2, can autofluorescence effectively direct excisional debridement? So our patients all had clinically infected wounds. They had adequate vascular supply. This was the first surgical debridement of this wound. And between debridements, each patient received negative pressure wound therapy. In the OR, patients received pre-debridement swabs and fluorescent images. They had excisional debridement, irrigation, and then post-debridement swabs and fluorescent images for comparison. So what did we find? Our patients were about your typical lower extremity wound patient. We had 33 who completed our protocol. 58% were males. They had an average age of 58. Their presenting A1C was 8.5. And about 61% were related to neuropathy. Now, as far as our wounds, we had about 15 were on the forefoot. It's about 45%. And the rest were distributed among midfoot, hindfoot, ankle, and other places. Our size was 16.8 square centimeters, and about 61%, again, were neuropathic. Now, if we look at this autofluorescence, we see that between pre and post debridements, we have a significant reduction in the amount of red fluorescence that's showing up during or after debridement. This held true for our second debridement as well, both statistically significant. Looking at our cultural swabs, we see that with semi-quantitative swabs, we see a similar pattern of significant decrease in bacteria post-debridement. Now, if we look at quantitative PCR, we don't see the same pattern, but over the course of 2 debridements, we see a trend towards lower bacterial counts. This amounted to a 77% reduction in viable bacteria. So correlating between the autofluorescence and the swabs, we see that we have a similar trend of decrease post-debridement cultures, which correlates to the decrease in post-debridement autofluorescence. So what can we make of this? First, we'll go back to our questions. Does excisional debridement significantly reduce bacterial bioburden? Yes, serial operative debridement does reduce bacterial bioburden of wounds. This is consistent with other studies showing that there is a ineffective clinical debridement with bacterial bioburden, suggesting that operative debridement is the ideal place to perform these debridements. And second, can autofluorescence effectively direct excisional debridement? Yes, changes in bacterial autofluorescence correlates with swab cultures in detecting these changes of bacterial bioburden. Thank you.